It's really good to be here with everybody today. I've entitled my slide, not quite the same title that you have, but after the pandemic, and after is in inverted commas, I might add, which we'll come back to, future challenges for the UK Health Security Agency. And I think one of the difficulties with joining a group like this to talk is I could talk forever on a global pandemic preparedness. And what I've chosen to do is just talk a little bit about the UK Health Security Agency, and then using vaccination as an example of preparedness, perhaps to take forward some of the interdisciplinarity issues or opportunities that we have going forward. So this won't cover everything, and I'm really looking forward to answering questions at the end, because I think that often brings out the real content that we're all after. In a week where it seems that everyone is giving their own version of the pandemic ahead of a public inquiry in various publications, I'm not sure whether this is a good week to join you or not, but I think it is important that even through various quite broadly framed documents, there are still a number of themes coming through, and I think we already have the opportunity to learn for the future. So as I said, I put after the pandemic in inverted commas, because actually we aren't after the pandemic. Of course, we are very much in the pandemic, and I'll come to some of the things that we do at the for the time being. And I'm going to look quite broadly around what the future challenges are, but really to say, at a point when the pandemic has caused great damage to lives and livelihoods, it has necessarily been a catalyst for incredible innovation that will prevent harm in the future, and I really want to focus a little bit on that. So I'll do my famous next slide, please, and head off through some slides. So next slide, please. So just to reinforce, UK Health Security Agency was actually born in the middle of a pandemic to prepare and respond to pandemics. And our sort of flagship motto is, we're making the nation health secure, whether that means contributing to national and international security, very much within the security forces, but also very simply but profoundly working with local communities, particular cohorts of the population, and also keeping very much in mind health inequalities and those who live in areas and lives of inequality who are likely still to be most impacted by a pandemic or other external health hazards. I've just come back from the annual conference for the International Association of National Public Health Institutes, and it's been really interesting watching the different conversations, but actually with very similar conclusions and considerations, and almost without exception, everyone is considering how their organisation might change as it goes forward in light of learning from the pandemic. But particularly, we seem to be the only organisation which had actually been formed in the pandemic. Now, there's some really good reasons for why one might think that wasn't a good idea, but in some ways, I think it is actually giving us some advantage in this country now as to how we can work, and strands of work which we are unable to continue. So next slide, please. Basically, I think I have the best job in the world. It is that we all want to live in a world that's secure. Despite that, there are new and existing health threats constantly emerging, and we'll come back to some of those shortly. Next slide, please. And broadly, we are the nation's expert health security agency, and we prepare, prevent and respond to these changes. One of the critical components of that is to build the public health and specialist capacity that we need as we go forward. And because health protection is global, we've seen that very vividly and tangibly through the pandemic. That capacity building extends right across the world internationally. And in fact, we have very significant global health protection operations work going on, supporting other countries to enable and reinforce their own capacity in response to compliance with international health regulations. And we have some very important work going on through the National Variant Assessment Platform, which is enabling other countries to learn from and benefit from some of the skills that we've developed in genomic sequencing. And because of that, we actually bring together 3 different organisations. Just for those who perhaps are less familiar, we've got the science and clinical elements that used to be in Public Health England, but importantly, we have very new expertise. So we have absorbed, taken in NHS Test and Trace, which has incredible logistics capacity, which other parts of government actually don't have. And this is quite an important learning point, both for this and for wide research as well, huge population research. And then critically, we have what was built as the Joint Biosecurity Centre, but is the data analytics and surveillance operational expertise that we now use. And again, I'll come back to that in a moment. So next slide, please. So when we are working with, I'm going to say with you, because we work with just about everybody, which I'll show you shortly. We are spread right across the country. And in fact, although we work very closely with the other devolved administration health protection systems, so Health Protection Wales, Health Protection Scotland, we do actually even have staff working in those countries already, particularly in chemicals, radiation and environmental response, so both in Scotland and in Wales. Next slide, please. And these are, it's a busy slide, but probably just signals the numbers of different stakeholders that are critical for preparedness. Now, these are principally UK in the middle, but if you look at either end, we have global at the top and then regional and local. And one of the things which the UK Health Security Agency does, which increasingly I'm finding, it was my belief, but I'm testing out, is really a unique feature, is in this country we can reach right from and working with a Prime Ministerial, Cabinet or Secretary of State decision, right out through our health protection teams, working very closely then with directors of public health and into every community across the country. But equally, we can extend upwards. So many of our specialist teams, as I know Graham will know and others, are working with specialists in other parts of the world, and that's critical to pandemic preparedness. For example, we've listed the Robert Koch Institute there, and I was working with their director last Friday, but equally slowing work a little bit with ECDC, but still the professional relationships continue, even if some of the political ones at times get a bit sticky. But so the spread for this is absolutely huge, and that is vital because we cannot respond here if we do not have the information from overseas, but equally really important that when we're working with other countries, we are also learning so much from them. And the likelihood is that if another pandemic arises, the first observation of that is not going to be with some genomic sequence that pops up. The very first observation and warning sign is likely to be a primary healthcare setting with a very observant local GP or community worker who spots that there is a cluster of disease which is presenting in an unusual way, and from that our notifications will increase. Next slide, please. So we've taken a remit really about preparing for the next pandemic, for preparing so we're ready for future health security hazards, that we have the best response system in the world so that we can save lives and reduce harm, even if we can't prevent the event happening. And as I said, critical to that is about building the health security capacity at local, national and global level. And then next slide, please, is a busy slide, not to do the detail, but it's very much to say that we work in an enabling role. It's not, we cannot work independently. It's absolutely vital that we work with others. And this is it's a slightly older slide here, looking at mpox and flagging, both right in the top left-hand corner, the data signals, the work from our rare and imported pathogen laboratory, working through high consequence infectious diseases network, working with the media, but particularly with third sector and advocacy representative organisations, and then with all the different clinical groups and with the wider population. So, and then obviously presenting much of that data to WHO to alert international organisations, because we were the first country in the world to spot the issue. Thankfully, the vaccination programme, the brilliant work of our communications teams and the advocacy groups, our frontline healthcare workers, and most particularly the public in these groups, has meant that Behaviours Vaccination has managed to contain this for the time being, and we will shortly be going out with a, if you like, a mid-term strategy for mpox control. But I think it just goes to signal the number of complex interactions there are, even when something has been identified in this country, that we then need to follow through on. So next slide, please. What I just wanted to do was really just use vaccination as an example. Now, it's hailed as the most successful part of the pandemic to date. It's often, I think, considered something very simple, that a vaccine gets out into an arm, and it's judged by the speed of that delivery to the individual. But of course, this is a hugely complex system to operate, and it becomes absolutely critical when we're talking about pandemic preparedness. So this is a painting of Edward Jenner. There's a clue at the bottom left-hand corner performing his first vaccination, and anybody who perhaps came to our conference, if you didn't, do come next year when we'll have an even bigger and better one. But this, I showed this at the conference, and then on the next slide you'll see how we have transformed vaccination moving forward into the pandemic era. And this is Margaret Keenan, who was the first person in the UK to receive a COVID jab, and then May Parsons, a matron from Coventry, who was the first healthcare professional to administer one. This is quite an iconic slide. I think for those of us who've worked in public health, we could never have anticipated previously that a vaccine could have been developed within a year to be out and administered safely, with all the correct robust processes and checks going through, with all the right evaluation ongoing, and with a strategic intent to ensure that those who were most vulnerable were protected and lives were saved. And this is, as I say, it's quite iconic, because much of the work that we're doing going forward, it revolves around how can we make sure that this learning is captured and available ready for every future potential catastrophe, as we have with the pandemic. But of course, it's not simply that we are thinking of COVID. On the next slide, please, you will see, and hopefully you will have seen out in the media, the fact that you have to think of vaccination within a much wider context. So as soon as we have a new vaccination programme for whatever the current threat is, there is a further interaction. And what we have seen, you can see it with children's diseases at the moment, we have disrupted our normal patterns, seasonality patterns. We have a COVID virus which hasn't yet adopted one. And so the boosting of immunity while these patterns settle down, and the increasingly complex messaging out to the public about what is the right precaution to take, means that not only are our comms team very active with their colouring pens, so we now have blue and yellow associated with flu and COVID respectively, but it becomes a very tricky message. And I think this is one of the things we've seen as we respond to a health threat. The early intervention is mission critical, but feels quite simplistic. As it gets further on, very much in the pandemic, not after it, the interactions both in non-pharmaceutical interventions, as we've seen, so the dreaded lockdowns, or the very simple but really important messaging about ventilation, for example, or social distancing, become very complex, as do people's actual immune response. Next slide, please. And what we can see here is just an update. So this is data up to the 30th of November, really highlighting how successful the COVID programme has been in the UK. And it is very much, that programme focused very much on at-risk groups, systematically applied to the whole population, and with brilliant uptake from the public, which has been really the making of us all getting back to some degree of normality. And you can see there that we're nearly up to 94% in first doses. For individuals in the older age groups, which is the dark line right at the top, we're well over 80% there for vaccination. I think that's the autumn booster. So these are really life-saving interventions, but of course they're not being administered equally to everybody. We still have significant sections of the population, often those most likely to be severely impacted from infectious disease and other health hazards, who are least comfortable and least confident to take them up, and that's an important part of our future communication. Next slide, please. But one of the really important things is actually the ongoing activity. And so, as I say, a vaccination rollout, logistically extremely difficult. Huge praise to NHS colleagues, to our own UKHSA staff who oversee the logistics of the supply, the commercial teams, the vaccine task force, now the COVID vaccine unit in the UKHSA, for getting this whole system up and running. But this actually is, we're currently now looking at new variants, but this was a slide just as an example of the work that goes on regularly in Porton Down, where we are looking at neutralisation activity. So samples taken from serum from recipients of 4 doses, against new variants, and you can see the variants listed across the bottom, and you can see that against the wild type, so in the top channel, we're getting consistently lower but still pretty good protection from the vaccines that we have. Now this work goes on continuously, so every time there is a significant variant, we are testing it. So currently we are looking, for example, at BQ1, and that is ongoing as I speak. So these are important components of pandemic preparedness. It isn't simply that we found something and we found a single vaccine, job done, which I think is perhaps how it was first considered. We now have brilliantly multiple vaccines using new technologies, increased understanding, so the ongoing research on this is really important. And we have to keep monitoring these. We also keep monitoring at the same time the lateral flow devices against different variants to make sure that they are all working as we would expect. So I think importantly here, there is a long research programme which has been established, and thanks to some very early thinking right at the start of the pandemic, some brilliant research programmes, both in acute care in hospitals, but in the community as well, has given us very good understanding of very simple treatments like dexamethasone, which we've been able to share with the world and undoubtedly save lives. And this sort of information also is published regularly through our technical variant briefings. And one of the considerations, if you like, or the premises on which UKHSA is working is that we will be a leader in transparent information. I think historically, and I know I'll be speaking to a number of people from academia, there has the natural insight is to have your piece of new insight, hang on to it, get it ready for published and put it out there, and the accolade will go with that publication. I think what we've seen through the pandemic is something very precious and to be considered as a long-term benefit, is that people have been willing to work together, willing to share information earlier because they know it was going to save lives, and to work collaboratively, exactly as Graham has said at the start, across disciplines to ensure that the right information gets to the right places for health protection action. Next slide, please. And one of the interesting points from this is, which is the opportunity and our preparedness, is how can we use this going forward? Now, this is a published pipeline of various different vaccines, pan-coronavirus vaccines, that were known. So obviously this starts to become quite commercially sensitive information. So these were back in May 2022. We were the first country to approve a dual COVID vaccine, which was targeting Omicron. And of course, you will see recurrently suggestions of universal flu vaccines or vaccines currently, new vaccines being trialled for Ebola, for Sudan Ebola in Uganda. And I think on the one hand, it's hugely exciting. And on the other hand, actually, the debates are still not finished. So on the next slide, please. Again, I was very lucky to be able to contribute with colleagues from UKHSA at the National Vaccine Conference in Barcelona earlier this year. And we had some really interesting discussions about whether it is better to try to create broad protection or whether, in fact, we should be moving to what is seen as, if you like, the plug-and-play mRNA vaccines, where you are targeting different variants. I don't have time today to go into the particular details of that, but there are a number of reasons why technically these are quite difficult to do. For some, it will vary with the different pathogen, but equally why building up immunity is quite difficult to describe, excuse me. So we already know from our research that that if you have had a previous infection plus vaccination, you are likely to have a broader protective response to COVID. And it's this sort of long-term understanding that we need to get from the different vaccine approaches. And I think at the moment, the jury is still quite out on this, although with lots of excitement. Next slide, please. And just to flag here that in UKHSA, one of the things we're doing, again, building from the learning from the pandemic, is to develop a vaccine development and evaluation centre, which acts as a front door for pharmaceutical companies to enable us with all the appropriate governance to work with them to manage, to ensure that the public health risks that we see in the infectious disease world are running alongside the sorts of developments that they might be able to support, rather than having the two streams of work completely separate, without increasing both the financial risk, but most importantly for me, the health risk, when we could be working much more closely together with real impact on infectious disease. Next slide, please. And again, not for looking at all the detail, but in fact, rather uniquely as an organisation, we offer opportunities right the way through the whole of the vaccine development pipeline. And I think until that we've looked at this through the pandemic, neither we, if I'm being honest, I think predecessor organisations, nor the pharmaceutical industry, nor our life science colleagues realised quite how much we had in the UK under one roof. And this is a really important opportunity for us as we go forward. Next slide, please. What I've just outlined here is some of those considerations for the future. So it isn't simply that, so I think I'm being brought a drink because of my coughing, which is very considerate. It isn't simply that, perhaps if we could go on to the next slide, please. It isn't simply that we have a vaccine and it works and the organism has gone away. We clearly have a whole load of learning ahead of us. We're not sure what we can see great opportunities. We've learnt to develop vaccines in a much shorter time frame, still with the right robust regulatory processes. But when you start to put multiple variants into a single vaccine, or you have multi-pathogen vaccines, it becomes much more difficult then to collect data, for example, on impact, or to consider how regulatory bodies like the MHRA might approve them. And it's quite likely that some diseases will be covered differently by different vaccines. So it would be better to do one with the other. And what we've seen is a sequence of boosters. So one of the issues at the moment is we'll hear often that the antibodies wane at 3 or 4 months in the elderly, but actually most people are still getting pretty good protection several months longer than that. So I think it's the understanding and the focus of this on those most at risk of serious illness and hospitalisation. And the critical one at the bottom for me in learning from the pandemic is actually how can the vaccine industry, academia and national governments all work together to drive this development in a way, as I say, which is absolutely appropriately governed, but delivers real opportunities for us all to be ready the next minute the next pathogen genomic sequence pops up. Next slide, please. And just to flag another opportunity that we've had. So this is the pandemic dashboard, COVID dashboard, which many of you will be familiar with. We use that, we produce this from our data analytics and surveillance team, so started by the Joint Biosecurity Centre. This was probably the most popular website for a significant period of time in 2020, and has meant that we have extended information to the public and other parts of the health system where perhaps it hadn't reached quite as quickly, quite as openly, quite as transparently previously. Next slide, please. So I think, again, one of the critical points of learning for managing pandemic, but pandemic response, is at the end of the day, this is a public health emergency. And it is the public, you and I, in our not necessarily professional roles, who will actually solve the problem. And that raises all sorts of opportunities, but also lessons learned from how we can best communicate. And I would actually say better to co-create information for sharing rather than somebody communicating to somebody else. It's raised huge numbers of armchair epidemiologists, and sometimes that can hinder hazard control by people taking and publishing different views. But what we've seen actually through the tail end of Omicron and subsequently with different waves is, as the public have seen the numbers rising, undoubtedly they are taking their own actions and using data directly to manage their own interrelationships. And we can see that through things like Google data, where people are going, whether they're using different services. And of course, there are other engagements as well. We've seen social media, scientific and professional journalism. You only have to look at the moment to see the noise and anxiety created around strep A, and see how important that is. We know that people receive their information from other countries, so we need to be aware not just what we're doing, but what others are doing. And we're very aware of disinformation. But it also raises really important questions about how we train scientists and health professionals in the future to be under such information scrutiny, but also to use that privilege well to support population health. Next slide, please. So I'm just going to go off onto a slightly different tack now and look forward, because the organisation doesn't just deal with infectious diseases. As Graham highlighted, it deals with risks associated with climate change, biological threats and wider dangers. Next slide, please. And that last picture is rather reinforced here. My sense is that during the summer, when we had heat waves, many people who perhaps had not felt that climate change was something that they needed to worry about suddenly realised that this was very real, even for us in the UK. Next slide, please. And then when we look at how that impacts what might be happening in terms of risk out there, we know that around 58% of human pathogenic diseases are actually aggravated by climatic hazards, which are sensitive to greenhouse gases. And this, so obviously thick lines, more problematic, lots of different infections over on the right-hand side. But this is quite all-encompassing in a way that I think we haven't previously thought about in quite this detail before, certainly not in a holistic way of risk assessment and readiness. Next slide, please. Now, in the UKHSA, we sort of stopped and thought this feels a really busy year. Just in the time that we've been here, which is only just over a year, we have had cases of Lassa fever. We have the highest numbers of premises infected with avian flu. We've had Mpox. We've had hepatitis in children. We've got strep A infections rising rapidly. And obviously we're contributing to support things like the Ukrainian response and the Ebola outbreak in Uganda. And we stopped and thought, well, we used to reckon we had around 10,000 incidents a year. So is it just that we're raising all these incidents up and managing them a different way and making more of it, if you like, or is this a real risk increase? And our conclusion is that we were managing and responding in just the same level, but these incidents now are much more complex. And some of that is to do with the system around us. Some of it is because we understand more, so we can delve into things more and they become more complex. But a lot of it, of course, is because people are travelling more, and what happens in one part of the world is going to affect all of us. Next slide, please. And so what we will see is, as I say, so polio is back in the UK after 40 years. These are infections and risks that we thought largely had been put out of sight and clearly are coming back in. And then on the bottom right, kinder products due to salmonella cases. The opportunities now for understanding foodborne infection, given sequencing opportunities, are also much stronger, but they are much more complex, and almost every food chain will travel internationally. So next slide, please. So I think that the scale of the challenge in preparing for security risks is growing, not just because of those issues, but because we are sitting in economic turmoil, we're sitting in climate change, and we're also sitting in conflict. And if we go to the next slide, what that principally means in the UK is that the three biggest risks I think we've had are COVID-19 pandemic, climate events, where we had our hottest summer temperature ever, which peaked over 40 degrees in July 2022. And I think, if I remember, that the temperature had risen 1.6 degrees from a similar period, the previous highest record in 2019. Now, clearly that won't necessarily be a linear descriptor, but it's a significant change, and I think it has really brought home the sorts of adaptation plans that we need to have to manage this, both in the risks around infectious disease, which I've just said, but particularly in how we live. And then coming on to that, a financial crisis probably wouldn't previously have been associated with talking about infectious disease, but it absolutely does, because people will take different actions. If your heating costs are very high, you will be likely to be huddling in one room, not heating your whole house. And all of these actions will contribute to the risks of pandemic growth and infectious disease prevalence. Next slide, please. And so one of the areas I did just look at, which seems quite a long way from pandemic risk, but is actually to look at slightly different behaviours. So on the bottom left-hand corner, you can see, rather sadly, that this is the UK GDP in grey and productivity output in the turquoisey colour. And you can see that we've had a big dip down in 20, as did most countries, but we are now heading off to a recession. And then you look at how we're behaving. And in fact, people are behaving in very different ways. So if we want to handle the public in the sense of supporting them to make good choices for managing risk in public health terms, we need to think how they are working, and we need to look at some of the wider risks. So on the top left, you can see that online sales have shot up and have not come back down to normal routes. So, and on the right, you can see that largely reinforced because the footfall through retail premises has also stayed down, even though the retail sales have gone up. So people are behaving differently. The number of vacancies you can see in the bottom left-hand corner, so this is ONS data from last summer, is health has very significant vacancies, whereas many of the other parts of the system were on furlough, and many in fact have come back to viability, except if you then look over to the right hand side, you can see that some individual sectors have increased. So gambling shot up, again a public health risk for different reasons, but air transport travel went down and has stayed down. Now again, good for sustainability and the planet, may not be good for those working in those industries. And if we go on to the next slide, again, it may feel quite a long way from how we manage risk, but these are really important. So where you have changes in global prices, it actually creates a risk which we saw come through the pandemic, and ensuring things like supplies for laboratories and the drive then to create our own life science industry in the UK to manage that risk. Also to note, of course, that our workforce is very different. People are leaving with a change in their lifestyle. Earlier, they're coming out in their over 50s and a huge reduction in the workforce, but equally the impacts of long COVID. And we sometimes forget those longer term problems. And then again, at the bottom, we're now looking at heating, for example, as a prescription as a health protection mechanism. Next slide, please. I think I've just got about 3 left. So on the, rather sadly, when I was looking back, and I think there is a warning here, this isn't a plea for my budget, but there is a sort of subtle warning in it, which is the World Bank in 2017 looked at the burden of large epidemics and flagged them mostly in health impact, economic impact and social impact, many elements of which I've flagged. And the key challenges over on the right-hand side are well known, and you can start to see them come into play now. So the first one is that as you get competition for resources to maintain pandemic preparedness, the thing that is nearest to you or nearest to ministers, politicians and the public becomes the thing to spend resource on. And so there is an immediate risk, which I observed in every country in conversations last week, is that whilst public health has been seen to be right at the forefront, health protection is now starting to drop down as people consider the pandemic is over, probably just at the time when globally we need to step this up. One of the other problems is if you have a major pandemic about once every 100 years, or that's what's quoted naturally, people see it as a very distant reward, if you like, a direct reward from investments, and so there's a reluctance to invest in that, and you will get competing projects from constrained resources, quite rightly too. And then the really critical point I just want to flag here, because it seems to me it is the biggest learning from the pandemic if we're going to tackle global health security, is that we need multi-sectoral, cross-department, multi-level coordination and efforts. And we've seen that both in research, in how people work, in how information is exchanged, and actually even in kits being exchanged across countries. And it's obviously one of the areas which was not fully managed, I think, in terms of vaccination access, which we still are acting on. So 2017, we're now 5 years later, and there's a slight feeling, more than a slight feeling, that we're starting to move away from that learning already. Next slide, please. So I just wanted to flag a few things that the opportunities, I think, that we found as the National Health Protection Organisation, because they're things that we want to develop and I think are important for our preparedness. The first one is, as I said, working with industry, because we have now included the Vaccine Task Force We will also be including a chunk of the antiviral therapeutics task force as well. And what that means is we can set up horizon scanning for new viruses, for new pathogens, and work alongside industry. So we're much further along that development line and ready to go with products much earlier should we need to respond. We've learned to work much nearer to ministers, which comes with its opportunities and challenges, but it means that you are able to influence policy and investment far more than if you're away from the table. We've also set up a Centre for Climate and Health Security because that is an area that I think has been underestimated historically for health protection in the UK. And we're investing in other areas which traditionally have not been considered so strongly, so radiation and chemicals. We're redeveloping the National Risk Strategy with the Department of Health that becomes our highest national risk has always been flu. That still remains an influenza pandemic, but considering a much more pathogen agnostic approach. And then the National Biosecurity Strategy is being reworked, and we're contributing significantly to seeing how we can do data differently for that. Next slide, please. And then two final points, which I've alluded to already, data and technology. So the COVID dashboard is actually a huge interventional tool. It's what the public have used to gauge how they want to act and how they manage their own risks. But importantly, we have learnt new skills around data linkage for communities with directors of public health, so they know where to focus and what's happening. And data linkage for systems, so linking the vaccine evaluation. In fact, the pharmaceutical companies, when we had very large public testing operating, we could actually do evaluation much faster than they could in setting up their routine studies. But equally, we've got new ways of pulling data from laboratories to ensure that we've got much nearer real-time appreciation of what's happening. And then critically on the bottom, there has to be a focus on inequalities for health hazards as we go forward, because nobody benefits if we don't, and those who are most impacted deserve that the most. And so the last two slides, the first one, next slide please, just says, for myself, I think there is an opportunity here. So it is about, yes, being the national insurance policy for the country in terms of developing health security approach, but actually that's quite costly for the country. We've seen that through the World Bank study. And so working with life sciences and building, using our skills in peacetime from pandemics and other hazards is a way of balancing those two slightly differing views. So it's an explicit two-channel approach. And then the very last slide, I think, just puts the headlines of the three key points that we've probably picked up from the pandemic in terms of preparedness. So one is we have to be flexible and be able to adapt at pace. We have to work in partnership right across lines that perhaps traditionally we haven't crossed. We all, between us, whenever we can jointly, tell the same story, definitely tell the story and identify the opportunities to bring the public along with us, but to support innovation and development. And then finally, we need to share models and approaches that work, and that's both between ourselves, between disciplines and between countries. And I think that's the last slide, and very happy to answer any questions.
Jenny, thank you so very much. That was a really comprehensive overview. It's been absolutely brilliant to hear about the work of the UK Health Security Agency, and as a consequence, we've got quite a few questions. I don't know how we'll do before 5 o'clock, but let's start. Well, you're obviously an advert for the Health Security Agency, because the most popular question was, what type of graduates and qualifications are needed to work for the UKHSA?
Anyone and everyone. So I should have put a sort of advertisement board out, and we are actually, I could do a little plug, Graham, thank you very much, because we are actively recruiting. We've had a very temporary workforce, which you'll be aware. We have lots of adverts out there, so please do go and look for us, because First of all, we recruit on mission. We have the best mission in the world, which is to protect people and to save lives. And the organisation revolves around that as its primary purpose. And so that's your first criteria. But then there are roles in almost every aspect you could think of. So you might come into the civil service and come in as a fast streamer or as a graduate entry to learn policy and work your way through the system. That's entirely possible. I've got, the person who just came in and kindly brought me my water, it's her first job straight from university, and you're exposed to all of this detail. But also really keen to recruit in for data scientists particularly. We have commercial needs, we have lots of different commercial contracts, and it's important even in a response, so for the Mpox response, getting new vaccine into the country, the most important people probably after the initial surveillance was for commercial individuals, but then on our research side, all and everything. So obviously laboratory staff, biomedical scientists, researchers coming through. We have our own PhD students as well. So just send something in. We'll almost be certainly interested in you if you pass the mission test.
Thank you very much. And from my own perspective, you also have a really strong behavioural sciences and mathematical modelling group. So really multidisciplinary. So how confident are you that the government's public inquiry on the COVID-19 response will help future strategy?
That's a very difficult question, I think. And in fact, myself and CMOs and the medical director of NHS England have just published something, not to preempt the strategy at all, but actually it was to ensure that the key clinical messages that we had learned didn't get lost in many ways, and they were readily available to support conversation. So that is out in the public space. But it's an example of where the public inquiry is, I think, looking to paint a picture of what's happened and then delve deeply into it. It's obviously started and it's quite early days. People will have different perspectives. To my mind, the important thing is that it enables the objective evidence to come through. That is really important. I mean, this has been for all of us, this has been a really psychologically important event, just as much as it has from a scientific and health outcome event. And I hope that the public inquiry will look at it sympathetically but objectively so that it can pull out those lessons. And I think so far, all of the messaging, as an organisation, we're being asked for huge amounts of information. It's quite a task. There is a balance point here, I think. But it appears to be moving that way. So I'm quite optimistic at the moment.
You mentioned climate change. Climate change has been identified as the most important health threat of the century. First of all, your thoughts on that, and what is UKHSA's strategy to address the threat?
So our role is very much as a health protection organisation. So when we're looking at climate change, we are looking at that particular angle of it. That doesn't mean to say we're not interested in the broader side of it. It's just that other people are doing that. And so when we work, as I've explained, I think in many of those slides, we work to support other parts of the system. So BAYS does a lot of work, DEFRA, business, environment, industrial, Office do much of the work. DEFRA does work, for example, in other areas and leads some of the work on One Health. So all of these, Food Standards Agency is also doing work on food security and various other things. So it's what we contribute to that, and our focus is on the health protection side. And so the Centre for Climate and Health Security is effectively our answer to that question, which is it's starting off by trying to put in one place a really strong evidence base of what can improve things. So quite practical areas, building where we are. So we contribute to the National Adaptation Plan, and we'll continue to do that. But what we're trying to do is put in place as a starter the evidence base so that policymakers can take the evidence from that and use it in the approaches they're doing. But I think the question is, I would say we have not had as strong a focus historically on the health protection side on climate change. And I'd like to think, and I know we've had a lot of support, that starting that particular area of work and advertising it is a strong signal that this is now an area of huge importance.
We have a strong faculty of the built environment at UCL, Jenny, and there's a question here: what's being done to ensure that the design of health buildings, clinical buildings, will change to further reduce nosocomial infection and to allow safe visiting?
Yes. So I always preface everything saying that nothing is ever completely safe. It's safer is always the way you do things, and I think that's fair. So I mean, there's been some interesting learning. So there's an environmental group that did a lot of work. It's one of the areas in the pandemic where I think it became very evident to all of us that actually we didn't have sufficient knowledge, and there had been an underemphasis, if you like, or overemphasis on some areas of transmission, and this was an area which was under-evaluated. So Kath Noakes has led a subgroup on SAGE and is continuing to do some work on the environmental group. So I think more to learn from that and recommendations. Certainly, I think if it's not out soon, there is a new publication coming out on ventilation very shortly from that group. And then I think it's what is the evidence and how does it feed in? So I've said we will try and find the evidence, but in terms of getting changing buildings, of course, this is a really difficult area because we range from very modern buildings to, Victorian ones. And rather bizarrely, actually, of course, in very hot weather, often some of the old Victorian stone-walled, high-ceilinged buildings suddenly come into their own. They're not very good in winter if your energy therm price has gone up sixfold. And so I think it's an area we will contribute to, but not one that we necessarily lead on, but we do feed into the National Adaptation Plan.
I'll have to just read the next question because I can't quite interpret it. How to balance government cost of the pandemic threat, I think it is, and citizens' needs for UKHSA? I
suspect that's the economic balance point, which I was alluding to, I think.
Yes.
And I mean, this is one of the areas where I say that is a political decision, not talked out of it, but quite rightly, as we've seen through the pandemic. And I think Chris Whitty would often say there isn't a good answer here, it's the least worst option. And I think that applies currently, and effectively we need to get good evidence to ensure that those choices where there is a balance are fully informed. They're not easy ones, and as I've demonstrated slightly with the heating, for example, and the household, and the fact you'll all be huddled in a room or you turn your fridge off and get infection risk somewhere else, there are consequences from taking actions in different directions. And I think in answer to that question, having good evidence where we can get it and ensuring that the whole balance of benefit and cost is understood as best it can be, because an initial reaction, as we all know, sometimes leads to something which creates more negativity, or it can be amplify an opportunity. So I think really difficult, definitely a political one, I think, is my response to that.
Very good, thank you. Just a couple of more questions before we end, and I'm going to use chair's action and choose what I think are the most interesting. So actually the top one is, given we know there'll be new epidemics, pandemics in the future, what can we do to increase essentially the layperson baseline understanding of global health security? I suppose that's again something that you did mention, Jenny.
So I think this public communication and engagement. I always say to people, when I was training in public health before, and I come from a broad public health background, not just from infectious disease, and I would say if it was health improvement, so stopping smoking or better diets, whatever it was, it should be noisy. If it was noisy, you'd know you were having an impact because people would start arguing with you, but that was good. And if it was health protection, it was very quiet because you were managing the incidents and nothing was coming up to the top. I've completely changed my mind with the pandemic, and I think we need to have, as a representative organisation, an ongoing engagement, both ourselves with media. So we are being, through the pandemic, in fact, much more proactive. So we work directly with Science Media Centre, or we will do quite detailed science briefings with science and health representatives off camera, in order that we give them a much broader understanding so that they can then share that indirectly into the public space. And then I think working with directors of public health, the really important thing here is an individual needs to receive the information from somebody they trust, or it's lost information. And so working with directors of public health, with different population representatives who are at risk. So for Mpox, Graham, you will know that you won't have seen the UKHSA banner very often. Actually, what we were doing was supporting other groups to give them material to take out through their different channels, because that was a much more trusted source than a government agency with a title that says health security, at least until everybody knows us better.
So, final question then, given infectious diseases don't respect borders, how does UKHSA and the UK government help developing countries?
Well, so I did allude to a few of the programmes. So the NVAT programme, this is the new variant assessment platform, is a good example of something quite technical that we do. So this is our own genomics team here working with a number of other countries. It's around 9, I think, at the moment, where to support education and training so that those countries can go on to do it themselves. But equally, if they don't have the same digital infrastructure, we can process their data for them and then give it back, so to speak. That does two things. Primarily, it enables countries to learn new skills and retain them for the future. But it also helps us and them understand the variant patterns across the world. So that's helpful. But we have Foreign Office funding and have had a programme running for many years under the Development Aid Programme, where we're working with other countries and we send out people, experts, to help support training. And a really good example actually is Pakistan, where there's been an ongoing programme, I think, for about 5 years. One of the learning has been to support them to put in their own surveillance programme, which they've used for COVID, but then in the recent floods, which of course are a climate risk, they've actually managed to use the same system themselves to convert that to notify infectious disease linked to flooding. So there are a number of countries that we do that with, particularly working also with Nigeria, African CDC, and we'll continue to do that. And the National Public Health Institutes Association is a high-level forum, but creates a lot of on-the-ground work. So we exchange ideas and support each other across that as well.
Well, we've run out of time, Jenny. Thank you so much for coming along this afternoon. I say coming along, I can see you're at Nobel House, the UKHSA's headquarters in Smith Square. It's very good to see you there. And what a great public health voice for our Public Health Voices series. It's really been great to have you. Your overview of UKHSA, absolutely, but your understanding of COVID and other threats to our health security and how we're responding to them is really inspiring. So I'd like to thank you very much indeed for coming today. And you've worked out from the first question, we've had a lot of students online, and I think you might be getting some more applications.
I was going to say, do everybody, if you're online, and we are the best organisation you could possibly come and work for, do come our way. We'd be really pleased to see you.
Well, thank you very much. Enjoy the rest of your evening. Thank you to all of the people who've tuned in today to see the webinar. Greatly pleased that you were able to do that. And thank you to our technical staff for doing the slides and getting us through without any hitch at all, as far as I could see. So once again, thank you very much. Thank you, Jenny. Bye-bye.